Yeah, good afternoon, all speaker and audience. Now we start the afternoon session with the academic international session. At first, I want to introduce Dr. Bat-Ireedui from Mongolia for the first presentation. Thyroid are family for low risk primary thyroid microcarcinoma. Please.
Thank you very much, Dr. Khan, and hello, Dr. Lee. Nice to see you here. And actually, this is my second time in city Ho Chi Minh, and I had it before in 2018. Maybe end of 2018, we visited in Ho Chi Minh and Hanoi. So, of course, this in the Wong Tao is my first time. It's pretty much exciting. How to share it is on screen too. So today's my topic is minimal invasive treatment for low-risk thyroid cancer, and I will emphasize about the role of radiofrequency ablation for PTMC. So that American Association of Thyroid, they mentioned about maybe 6 or 7 years later, thyroid cancer will be the fourth main cancer in the population. That's why we need to be ready to fight against, maybe make a deal with that kind of thyroid cancers. So this is, I also talk about some active surveillance and thyroidectomy and minimal invasive treatments. So what about active surveillance? This is American Association, as you know, that always publishing information about how to make a deal with some minimally invasive method for PTMC and low-risk cancer, and also benign thyroid nodule. We already know about how to treat and how effective the benign thyroid nodule is treated by thermal ablation, such as radiofrequency ablation. And less than 1 centimeter and the T1, N0, M0, low-risk PTMC can be cured by radiofrequency ablation. Of course, if they have some clinical lymph node metastasis, distant metastasis, and also recurrent thyroid nerve paralysis with additional elevation, and also protrusion into the tracheal lumen, provided they can be immediately go to the surgery, and also tumor suspected of aggressive type, subtypes such as Bethesda high scores. Of course, they need to go to surgery. So thyroidectomy. I just mentioned table 1, 2, it's about Bethesda score. And still, thyroidectomy is the main treatment option in many countries. Most of the head and neck surgeons, they are doing the thyroidectomy for case of medullary and follicular thyroid carcinoma. We will not touch like this kind of aggressive tumor. We will just talk about PTMC. It's low mortality rate, less than 1%, and also early stage of this kind of tumor, we can make ablation. So what about minimally invasive treatment options? So this is one is long ago we used the ethanol ablation for the cystic lesion, and also predominantly cystic, and also cystic lesion can be deep ethanol, but nowadays mostly for the cervical sponge form, like predominantly solid, this kind of things we are using radiofrequency ablation. This is we know that standard technique and transdisciplinary approach and moving shot technique is always recommendable as And that's why we are experiencing very low rate of complications. And here is just a short video about the easy to understand about moving shot techniques. And this video telling us many things. So we can see from here local anesthesia with eye dissection and also targeting how to guide development sequence to have to make an ablation. We call that the moving shot technique. And also we need to mention about hot lead valves and acoustic shadow bothering our bleeding part. That's why we're starting from the lower to up this direction. So this is a short video to make you understand about moving shot technique and transdismal approach. So if you have a radio frequency system and items, you can make those diseases, such as hypothyroidism. Hypothyroidism makes a big hypertrophy for the parenchyma, and hyperthyroidism as well, and goiter, Graves' disease, and Hashimoto's syndrome, and thyroid now acting thyroid cancer. This is talking about recurrent cancer or PTMC. So, if you guys following this technique, if you guys having some good experience to having radio frequency ablation for the benign model, you will facing very low complication rate. This study is gathered 24 more other countries study and more than 2,400 patients and many novels. And 2,786 novels treated by radio frequency ablation, and you can see that including major and minor complication rate is around 2.4%. Of course, it's needed good ablation technique and standard, so good correct patient selection is really important as well. So nowadays in Korea, it started 2006, and the radio frequency ablation in the world, and then American Association, Italy, and European countries. And I'm really happy that I saw the Vietnamese statistic. You guys started 3 or 4 years ago radio frequency ablation, and already ablated for 500,000 cases. And also I'm very surprised about liver cancer ablation. It's around 900,000 cases already did, which means this is so good experience that doctors working in here. So here is several guideline and standard protocol in the Korean Society of Thyroid Radiology. And this ablation guideline is one of the ways to learning curve. So here's around 10 years that active surveillance about recurrent thyroid cancer, and they can mention about ablation is also being used to low concerns with well-proven clinical efficacy. So recurrent cancer and PTMC can be cured by ablation. And this is a comparison with thyroidectomy and thermal ablation. And this is meta-analysis is published in Korean journal. And you can see from here 339 thermal ablation and 314 surgical thyroidectomy. And they have no significant difference between them. And also from here, you can see that the rate of complication is almost twice the surgery. Surgery patient can be like a more major complication. I will mention about this later. And you can see that lymph node metastasis and occurrence of new tumors and rescue surgery, that's not so big difference. But regarding complication, they can have some difference. So how about the thyroid function? As we know that if we targeting like only the unfunctioning thyroid parenchyma, it's not makes any influence thyroid function, because if we are not bothering, not affecting normal parenchyma, we will not touch. That's why all patients cured by radio frequency ablation, they can be within 1 to 6 months later, they can be normal, balancing the function. course, I gathered many of the countries study and to collecting here to introduce you guys. And recommendation, and it's recurrent thyroid cancer is why? Because the evaluation can be performed for curative and palliative purpose. And recurrent thyroid cancer, thyroidectomy, also cervical lymph node, and also recurrent lesion, and if patient is refusing and unwanting, or like high age people who wants to evade surgical approach, and maybe we can help them by ablation option. So how about curative ablation? First, it's really to cure the patients totally. We don't want to repeat ablation. We don't want to again any complication and something. We need to once ablate, once the procedure is going to be to go. So in this case, we need to select smaller, like until 2 centimeter lesion. This can be good effect because of thyroid electrode is bigger one is like can be like 2 centimeter. But in the recurrent or lymph node, it's not able to use sometimes moving shaft technique. That's why we just single puncture and ablate whole. Of course, we need some safety margin. That's why we need to make a bigger ablation. That's why we need to consider about the size of the tumor. And also, palliative propose and also like bridge treatment options. Like RFA can be 5 minutes charged at size reduction by RFA, and if case of the big recurrent tumor or lymph node or some unresectable like adjacent tumor, in this case we can make ablation to decrease symptom and also to give him influence to make a volume reduction. It can be helpful for patients' quality of life and also pain. So here's locally recurrent thyroid cancers, like smaller than 2 centimeters after treated by radical ablation, also published by Korean Journal. And you can see from here the recurrence-free survival rate is compared with within 5 years, which means 60 months. And then you can see here it's comparable, right? And then how about that the complication rates? We are talking about the major and medium complications. So nowadays, most of the complications can be dealt easily. For example, last time when I was in Ecuador and I faced one of my young patients, during my procedure, she felt feeling like a hoarse voice change. And then I just stopped my procedure and directly made the puncture and inject cold saline. It's easily cured, but no problem, the voice change within a few minutes. So this is another group, and the rehabilitation group is showing some complications such as hoarseness, hypocalcemia, and this dividing by transient persistent. You can see from that table, and there's a rehabilitation group is a little higher than other rehabilitation group. So of course, this image diagnostic is really important. Especially MRI is really sensitive. T1 phase is really sensitive for the metastatic lesion, and also PET scan, of course. But this is the CT scan also can detect easily that recurrent cancer lesions. Also the lymph node and not all the thyroid lesion maybe can be like a lymph or other organs metastasis near the neck area. And we have a ablation case card in the Facebook group, and from Vietnam and from Cambodia and from Mongolia, Korea, and even the USA doctors. We are collecting interesting cases in here, and you can see from the one of our Chinese and also Taiwanese doctors mentioning about floating Iceland sign. You can see here that they detect that the recurrent cancer in here, and then they are making a good enough hydrodissection with dextrose 5%, and then they are naming this one floating Iceland sign. This is really nice technique. And after that, you can make a nice puncture and make a hole. This is good enough ablation. It's really nice. And Professor John Beck is also mentioned about the rupture of after this field case, but it's can be like these kind of things, and then have to make a deal like this kind of problem, and this mentioned about this. So you guys can join this ablation case garden, and you will see interesting case reports over here. So again, PTMC and has a high incidence and good prognosis. And as I mentioned before, the mortality rate is just 1% less than, and you can follow up and you can observe like this. And surgical operation for all PTMC might be an over treatment, and then actually that this American Association and also brain study, all studies showing us this unwanted surgical number of the surgical approach and surgery can be decreased if we actively doing radiofrequency ablation for this kind of PTMC. This is a really good low complication rate, that's why it's also effective. So major and minor complication, and we have mentioned it, and you can see that no major complications encountered, and moderate pain can be, like, we can have some painkillers, and transient hoarseness that can make easily deal. Just during the procedure or right after the procedure, you guys can inject a normal saline. This can be cured by easily. And most of the discomfort, voice changes, they can make it very easily. Of course, now we will not do any skin burn or some technical and some iatrogenic unity void, but it needs to be to increase the number of technique. So sometimes this can be like non-anatomical things. In this case, maybe like a brachial plexus injury, maybe it can be, but it's really rare. So maybe my next colleagues will mention about some new updated techniques, but anyway, once I talk about the Korean Journal of Radiology, they mentioned about now new nice techniques. Maybe this is not new for you guys, but I just would like to mention about this. And very valuable pain injection is really helpful to decrease the pain, vomiting, patient complain, and they will not feel that if you have good peritidal local anesthesia, that's a really good technique. And also arterial first ablation, and you can see that with color Doppler ultrasound, where is that benign and malignant thyroid cancers, tumor feeders from where. And as you know that ablation is really good for that small angiogenesis. We can stop easily that angiogenesis. Once we give it a high temperature, high watt, and once we ablate the feeding vessels, starts from artery and draining veins, it's really helpful. And you can see artery first ablation technique. And once we decrease the feeding arteries, and then we can deal with veins as well. So here is again about hydrodissection technique to avoid some maybe can be vaccinated in here, carotid artery and jugular vein. Sometimes anterior location, posterior location of the vaccinator can be avoided by this hydrodissection. And venous ablation, we know that most of that benign novel and also regrowth is due to the marginal vessels. That's why we need to make marginal ablation, feeding artery ablation as well. And safety and complete is always we need to consider. One side is safety ablation, the other side complete ablation. We need to make a balancing, otherwise we will make some problem. And we see that ultrasound is really helpful, and also the visible on the ultrasound very clear is really nice. And great looks is our electrode is really clearly visible on our ultrasound. That's the really nice one. And always mind about your view. It's technically it must be good to be good experience. So this benign thyroid nodule can be managed by radiofrequency ablation safely with lower complication rate. This is already we are all known. Especially, I'm so happy when I see the Vietnamese statistic. So many Arab ablation you guys already did. And the second is RFA can be treatment option for recurrent thyroid cancers and alternative to the surgery. And then now is many studies showing us that there might be a considerable approach for low-risk PTNC. So we will not talk about medullary, follicular, and also dangerous subtypes. We can talk about PTNC bravely because we have some evidence-based things. So, and minimally invasive options can cure now low-risk PTNC and who can't go through surgery, who refuses to go through surgery, who had previous hematoidectomy, and who has anxiety because of the presence of the tumor. So, end of my slide, I would like to introduce the Asian Surgical Ultrasound Society Congress. This is maybe like a surgical ultrasound, but they have so many interested radiologists participating because you know that we are so helpful to the surgeons and also this is medical field. And I would like to please consider that the Congress. Thank you.